Welcome to another session in the series on surgery clinics, season 1. Today we'll discuss carcinoma of the cecum. Today I will start off with a short clinical history of a patient with carcinoma of cecum. The history is of a 68-year-old man who's referred by his general practitioner with a 6 weeks history of lethargy and breathlessness on walking. He has shown no fever, nausea or vomiting. He has loss of appetite and has lost 12 kg in weight over the previous 2 months. He reports no rectal bleeding or change of bowel habit. His father died at the age of 58 from colonic tumor. He is otherwise well and not on any regular medication. His GP referred him to the colorectal clinic as he was concerned about his blood results and his strong family history of colorectal cancer. The esophagogastroduodenoscopy (OGDS) has been done previously as requested by his GP and was reported to be normal. On examination, he was afebrile, conjunctiva are pale and he looks cachectic. There is no jaundice or palpable lymphadenopathy, the chest is clear and the heart sounds are normal. Examination of abdomen reveals a fullness in the right ilia fossa and a vague mass which was mobile was also palpable in the right ilia fossa. However, there was no tenderness or guarding and there was no associated hepatomegaly or ascites. A digital rectal examination is normal. With these clinical findings, a diagnosis of carcinoma of the right colon, possibly cecum or ascending colon, was made, and the patient was subjected to a number of investigations. Investigations included a colonoscope, which was done, and this revealed a large mass, fungating mass arising in the cecum from the lateral wall of the cecum here. It has areas of ulceration with bleeding and necrosis. It was followed up with a CT scan of the abdomen, which also revealed a large mass arising in the cecum, 5 by 5 centimeters, and well encapsulated, and this is the ascending colon. Biopsy from the mass revealed a diagnosis of adenocarcinoma of the cecum, stage T2 and 0. We now come to the lecture proper, carcinoma of the cecum. As you all know, the cecum is the terminal end of the large intestine. The first part of the large intestine, first 5 to 6 centimeters of the large intestine. It is found on the right side and is attached to the appendix, and it continues as distally as the ascending colon. It can be seen ascending colon and appendix. Now, right-sided colonic cancer. What are these tumors that conform this colon cancer from the right-sided? These include 3 groups of diseases: carcinoma of the cecum, carcinoma of the ascending colon, and carcinoma of the proximal transverse colon. The patient usually with these tumors usually present with unexplained pain in the right ilia fossa or plus or minus general symptoms such as anemia, malaise and weakness. This slide shows you the incidence of the cancers in various parts of the colon as shown here. The colon itself is made up of from the ileocecal junction, ascending colon, cecum, ascending colon, hepatic flexure, transverse colon, splenic flexure, descending colon, sigmoid colon and rectum. Now the incidence of tumor will be 40% in the rectum, 20% on sigmoid colon, and together they form the tumors in this rectosigmoid area forms 60% of the tumors. 60%. Now the next most common site is the cecum, which constitutes about 20% of the tumors of the colon, and the others are distributed throughout the colon: ascending colon, descending colon, transverse colon, and the sigmoid. Okay, this diagram shows you the arterial supply of the colon. Okay, we have got two main arteries supplying the colon. The first one comes from the the superior mesenteric artery, superior mesenteric artery here, okay, which supplies the right side of the colon through the ileocecal artery, here ileocecal artery, right colic artery, and the middle colic artery. The left side of the colon is supplied by the left colic artery, the hemorrhoidal or superior rectal arteries, and the sigmoid arteries. Okay, the branches of the superior mesenteric artery, the three main arteries that supplies the right-sided colon, ileocecal, right colic, and middle colic. Okay, now we come to the etiology. What is the etiology of the cancer of colon and cecum? Okay, there are three main conditions to look into. First, the colorectal cancers originate from the epithelial cells of the colon or rectum. Okay, so now you're talking about cecum, so it comes the epithelial lining of the cecum. Most commonly, the tumors are histologically adenocarcinomas. Okay, more than 95% of them will be adenocarcinomas. Rarer types include lymphoma, carcinoid tumor, and sarcomas. The second thing to consider in this etiology is the mechanism of cancer development. Now it is quite well established that carcinoma of the colon or the mechanism of development is the so-called adenoma-carcinoma sequence, where the tumor is postulated or confirmed to be originating in adenomas. Usually the normal mucosa changes to colonic adenoma or polyps, which then become invasive adenocarcinoma. Adenomas may be present for more than 10 years before becoming malignant, and progression to adenocarcinoma is believed to occur in approximately 10% of adenomas. The third factor is the genetic aspects. Certain genetic mutations have been implicated in predisposing to colorectal cancer. There are two main ones, adenomatous polyposis coli or APC, where the mutation of the APC gene results in growth of adenomatous tissue associated with familial adenomatous polyposis, which is pre-malignant. The second consideration is the hereditary non-polyposis colorectal cancer, or HNPCC, which is also known as the Lynch syndrome, where there's mutation to this genetic or genes which lead to the development of colorectal syndrome associated with Lynch syndrome.
Now, one of the popular theories or mechanism for the formation of carcinoma of the colon is the adenocarcinoma sequence, or ACS. Okay, this slide shows the phases of progression of the normal epithelium of the colon to sporadic rectal carcinoma. Okay, where it passes through the various stages of early adenoma, intermediate adenoma, and late adenoma. Now, this progression from normal to carcinoma is driven by the accumulation of driver mutations in the various genes that are involved, as shown in green here. These are the genes that are involved. Okay, so this is the adenocarcinoma sequence mechanism of carcinoma of the colon.
Okay, as for the risk factors for this carcinoma, there are two broad types. One is the sporadic type, where 70% of the colorectal cancer in this group develop in people with no specific risk factors, no family history, no genetic predisposition, there's no known risk factors. Okay, so this forms 70% of the patients. The remaining patients
some form of potential risk is present. And these include increasing age, family history, genetics, inherited gene mutations, inflammatory bowel disease, low fiber diet, high processed meat intake, smoking, high alcohol intake, and obesity.
Next, we come to the clinical features of cecal carcinoma. Change in bowel habit. These are the common symptoms. Will be change in bowel habit. So patient has got alternating with diarrhea and constipation, or patient has the habit in the bowel movements have changed. History of rectal bleeding, more so for the left-sided tumors. Unexplained weight loss or unintentional weight loss. Abdominal pain, especially vague aching pain in the right lower quadrant of the abdomen. Iron deficiency anemia. And classically, the clinical features vary slightly depending on the location of the cancer. In right-sided colon cancers, the cecum and the ascending colon, there may be abdominal pain in the right side, occult bleeding, mass in the right lower quadrant, anemia, and unexplained weight loss. So these will be the usual symptoms of the right-sided colon. In left-sided colon, from the splenic flexure down to the rectum, the main symptoms are rectal bleeding. Rectal bleeding becomes a more prominent symptom, unlike right-sided colon, where the bleeding is occult. Change in bowel habit, diarrhea, constipation, tenesmus, a mass in the left iliac fossa, which can be examined on per abdominal examination or per rectal examination. So these are left-sided colon cancer signs. Okay, cecal and right-sided carcinomas present often with anemia, which is iron deficiency, and vague symptoms such as weight loss in malaise, vague abdominal pain, fecal occult blood, palpable right iliac fossa mass, and they may even present as appendicitis due to the rare occurrence of cecal tumor blocking the entrance to the appendix. Distal obstruction. Distal ileal obstruction is a complication but is rare. Okay. This picture summarizes the various symptoms of cecal cancers. The patient is usually an elderly male or female or male, more than 60 years of age, pain in the lower abdomen, especially in the right lower quadrant, vague pain, vaguely localized. There may be a mass associated, which is usually non-tender. History of bloating and gaseous distension of the abdomen. Weight loss, unintentional weight loss or unexplained weight loss. Iron deficiency anemia due to occult blood loss from the cecal cancer. Dark tarry stools, nausea and vomiting. Now, the investigations for patients with suspected cecal carcinoma include blood tests and including hemoglobin and check for iron deficiency anemia, CEA, carcinoembryonic antigen levels is a good indicator, but it is non-specific and not so accurate. Fecal occult blood testing and fecal immunochemistry testing, FIT. X-ray abdomen may show a vague mass if it is present. Ultrasound scan of the abdomen is a very important screening test to rule out mass in the abdomen. Barium enema, it shows a typical apple core appearance with colonic cancer. Colonoscopy with biopsy and plus or minus upper GI OGDS. CT, contrast CT, contrast enhanced CT abdomen and pelvis, and lastly the CT virtual colonography. Okay, CT colonography, they call known as virtual or CT colonography. In general, patients with unknown anemia, anemia of unknown cause with loss of weight, needs to rule out carcinoma of the right colon, and these patients you must do a colonoscopy. The laboratory tests which I mentioned, routine test, full blood count, looking for microcytic anemia, iron and also liver function test. And the other important thing is a tumor marker, carcinoembryonic antigen, CEA. Okay, it is not a diagnostic test, but it's because it is poor sensitivity and specificity. But it is a very important serum marker to monitor disease progression and should be considered or conducted both pre and post treatment and screening for recurrences. I will show you some images or x-rays of these patients where investigations were done. This is a barium enema of the patient where it shows a stenosine Apple score. They're here, filling defect here, and their close-up will show an Apple core lesion here. Okay, this is another lesion here. It shows the Apple core carcinoma of the left-sided colon. Okay, here another one, the right side. This is the Apple core lesion here. Okay, this is the Apple core, and this is diagnostic or suggestive of colon carcinoma. Okay, a close-up of this is shown here. It's a very clear-cut lesion known as the Apple. This is the Apple core that is seen in the center of the lesion. Okay, which is due to filling defect and narrowing of the lumen of the cecum. Okay, this is a CT scan similar to the one I showed you earlier. There's a large mass in the right lower quadrant or right iliac fossa region, which is the cecal mass. This is the same picture I showed you just now, filling defect in the cecum with a suggestion of an Apple core lesion here. Okay, this is a distal cecum. This is the proximal cecum with the filling defect. Okay, this is another patient without colonoscope finding, showing you a lesion here. All right, the cecum here, multiple lesions. Actually, there's another one here, and this was shown to be on biopsy confirmed to be carcinoma of the cecum. And on CT scan done shows a well-defined or well-encapsulated mass in the right lower quadrant, and it appears to be in the cecum. Okay, these are other more colonoscopic images of cecal carcinoma. You see a polyploid lesion here. Okay, large polyploid lesion here with ulceration, bleeding, and necrosis. Then here is an ulcerative lesion here. Okay, this is an ulcerative lesion, necrotic and ulcerated. And here is the large fungating lesion occupying almost the whole of the cecum. Okay, this is a mass with ulceration and bleeding. Okay, this is the pictures, images of colonography or virtual colonoscopy, where you introduce air into the colon and then subject the patient to a CT scan. Okay, these are very good for the diagnosis of polyps, colonic polyps. This is a colon lumen, and this is a polyp here. Okay, this is a large polyp which is seen in the colon. There's another one, similar one here. All right. Now this is a virtual colonoscopy or colonographic image of a patient with a colonic lesion here. And this is the standard colonic biopsy, where the colon has a mass in the rectosigmoid area, and which has been biopsied and came back as adenocarcinoma. Okay, next we come to the staging of colorectal cancer. The most important, useful or popularly used is the Duke staging of colorectal cancer. There are three of main stages. Originally there were three: A, B, and C. A is invasion but not breaching the muscularis propria, that means within the lumen of the tumor, within the mucosa. B, breaching the muscularis propria but not involving the lymph nodes. So it is confined to the within the wall of the colon. C, when the lymph nodes, adjacent lymph nodes are involved. And D, which is added later into the modified Duke staging, and there's distant metastasis. Okay, Duke himself never described a stage D, but is often used to describe metastatic disease of the colon. Now, nowadays, Tnm classification is becoming more popular and more established, and these are the summary of the Tnm classification. Okay, and this include T is the tumor stage, as you all know. N is nodal stage, and M is metastasis. Okay, T is T1 into submucosa, T2 into muscular propria, T3 into pericolic fat or subserosa but not breaching the serosa, and T4 serosa is breached and directly involving the adjacent organs. Okay, so in this classification, again, T1 and T2 are considered early cancers, okay, where it is confined to the mucosa. And T4 is considered late cancer, which breach the organ and there is adjacent metastasis. Lymph node, N0 is no lymph node. N1 to 3 is N1 is 1 to 3 lymph nodes are involved, N2 4 or more lymph nodes are involved. And metastasis, M0 no metastasis, M1 metastasis present. Okay, this is the Tnm classification where you can see the T1 is confined to the mucosa. Okay, is confined to the mucosa, submucosa here, and T2 is come to the muscularis propria, involve the muscle, but still within the lumen of the wall of the bowel. It does not breach the wall. Whereas T3, it has breached. Okay, involve the serosa of the bowel. And T4, when it comes outside and involves the external, when it comes out of the serosa and involves the adjacent organs. Okay, next we come to the treatment of carcinoma of cecum. These are the modalities that are available: chemotherapy, radiotherapy, targeted therapy, immunotherapy, surgery, and palliative and curative treatment. Okay, among all these things, the most effective for cure is surgery. Okay, which I shall go in detail in a short while. Okay, what is the surgical resection involved? Okay, the surgical resection involves right hemicolectomy and extended right hemicolectomy. So this right hemicolectomy is for cecal and ascending colon tumors. Okay, and in this procedure, the three arteries are ligated and transected. They are the iliocolic artery, the right colic artery, and the right branch of the middle colic artery. Okay, these are all branches of the SMA. Okay, superior mesenteric artery. Okay, in the extended right hemicolectomy, is usually reserved for tumors of the hepatic flexure and transverse colon tumors. In this, besides the three arteries which I mentioned, iliocolic, right colic, and middle colic, the middle colic vessel is divided and removed with the mesenteries. Middle colic is ligated at its root, which I will show you in a short while.
Okay, this slide shows you the features of right hemicolectomy. As I said, these are usually for lesions of the cecum and ascending colon. Okay, and during this right hemicolectomy, the iliocolic artery, the right colic artery, and the right branch of the middle colic artery are all divided and removed, together with the right colon, which includes the terminal ileum, appendix, cecum, ascending colon, and the proximal 1/3 of the transverse colon. Okay, that the line of transection is here between the proximal 1/3 and the distal 2/3 of the transverse colon. In this operation, care must be taken to identify the right ureter, right gonadal vessels, and the duodenum, which may be very close to this line of dissection, and this must be identified and carefully preserved.
Okay, this is a right hemicolectomy. Removed terminal ileum, appendix, cecum, and ascending colon until the proximal 1/3 of your transverse colon at the hepatic flexure. Okay, and then you bring these two loops together and do a Iliocolic Anastomosis as done here. Okay, here again the tumor right colon is removed and the terminal ileum is anastomosed, Iliocolic Anastomosis. Okay, now extended right hemicolectomy, as I said, the distal margin of resection in this case is extended to include the splenic flexure. Okay, that means you extended the distal margin further distally in the colon. Usually it is 1/3 away from the splenic flexure. Okay, the proximal 2/3 of the transverse colon are removed together, and the arteries ligated will be the Iliocolic artery, right colic artery, and the middle colic artery at its branch, at its origin. Thereby, the right and left branches of the middle colic artery are also occluded in this resection. And these are usually for lesions of the hepatic flexure and transverse colon.
Okay, this slide shows you the difference between a right hemicolectomy and extended right hemicolectomy. Here in right hemicolectomy, the resection is portion of the distal ileum, appendix, cecum, and the ascending colon, right until the proximal third of the transverse colon. So the line of transection is at the junction between the proximal 1/3 and distal 2/3 of the transverse colon. And these are essentially for carcinoma of the cecum and ascending colon cancers. Whereas on extended right hemicolectomy, the line of resection is extended to the distal margin to include the transverse colon up to the distal 1/3. Okay, up to the distal 1/3 from the splenic flexure. Okay, that means apart from the right colon that is removed, the 2/3 of the transverse colon is also removed. And these dissections are for hepatic tumors on the hepatic flexure and proximal transverse colon.
Okay, this slide gives you the surgical options available for cancer of the colon depending on the site of the lesion. First, you have the right colon, which consists of the cecum and ascending colon. Lesions in these sites, you do a right hemicolectomy. Whereas lesions in the hepatic flexure, you recommend an extended right hemicolectomy. As for the transverse colon, you do a transverse colectomy or an extended right hemicolectomy. For left-sided tumors at the splenic flexure and descending colon, left hemicolectomy is the treatment of choice. Whereas for carcinoma of the sigmoid colon, sigmoidectomy or sigmoid colectomy or an anterior resection of the lesion is recommended. Okay, now we come to the prognosis of carcinoma of the cecum. And the Duke's staging system is still widely used in predicting the outcome or prognosis of the 5-year survival rate of colon cancers. Okay, for Dukes A, when it is confined to beneath the muscularis propria, the 5-year survival rate is high, 90%. For B, where the tumor is extension through the muscularis propria but confined to the wall, has got 65% 5-year survival rate. For Duke C, where the regional lymph nodes are involved, the percentage of survival rate drops to 30%. And for D with distant metastasis, it's less than 10% 5-year survival rate. So it is very important to detect the tumor at these early stages. A and B are considered early cancers where the prognosis is much better, okay, more than 60%. Whereas D and C are considered advanced disease and the prognosis is very much low, and especially the Dukes D with distant metastasis.
Okay, now we come to the summary of carcinoma of the right colon, which includes carcinoma of the cecum and ascending colon. These are important features or points that must be taken home as key points. Number one, the clinical features of right-sided carcinoma are mainly anemia and loss of weight. Unlike with left colon, where there is PR bleeding and change of bowel habits. The investigations mainly involved is colonoscopy and a CT scan. Colonoscopy with biopsy and CT scan for staging. The CEA level is useful in monitoring treatment efficacy and disease recurrence, not diagnostic. Number 5, staging is used. The disease is staged using the modified Duke's staging or the Tnm staging. Number 6, treatment, right hemicolectomy with Iliocolic Anastomosis. Surgery remains the mainstay of curative treatment for carcinoma of the right colon. Chemotherapy, radiotherapy, and target therapy are used for patients with advanced disease. The prognosis is good if the Duke's staging is A and B, can reach as high as 90% 5-year survival rate. And the most important point to underline here is any unexplained anemia with loss of weight, especially in elderly females, always must be investigated using a colonoscopy. Okay, now let's go through some questions on carcinoma of the cecum. Quiz number 1. Question 1. Which of the following statements are false? A. Right colonic cancer present with features of anemia. B. Left colonic cancers present with rectal bleeding and obstructive symptoms. C. For an experienced colonoscopist, the failure rate to visualize the cecum is 10%. D. Intravenous urography IVU should be routinely done. And E. Synchronous cancers occur in 5%. The answer is D. Intravenous urography should be routinely done. Okay, it's not done routinely anymore. Okay, question number 2. The common clinical features of carcinoma of the cecum. A. Megaloblastic anemia. Unexplained weight loss. C. Massive bleeding per rectum. Tender mass in the RF. The answer is B. Unexplained weight loss. Question number 3. Complications of carcinoma of the cecum include A. closed loop large bowel obstruction, hematemesis, spurious diarrhea, enterocutaneous fistula? The answer is D. Enterocutaneous fistula. Question number 4. A 64-year-old woman presents with a non-tender mass in the right ilia fossa for 2 months. The investigations for the patient include all except A. A full blood count including hemoglobin levels, B. A MRI scan of the abdomen, C. Ultrasound scan, abdomen and pelvis, colonoscopy. The answer is B. A MRI scan, abdomen. Question number 5. A 68-year-old man has a well-localized tumor of the cecum. A colonoscopy done revealed it to be adenocarcinoma. The CT staging done is T2, N0, M0. The preferred treatment will be A. Chemotherapy, B. Right hemicolectomy with iliotransverse anastomosis, extended right hemicolectomy, and total colectomy and iliorectal anastomosis. The answer is B. Right hemicolectomy with iliotransverse anastomosis. Question number 6. The 5-year survival for the above patient after surgery is more than 90%, less than 10%, 30%, 70%. The answer is A. More than 90%.
Come to an EMQ on colorectal cancer. Choose and match the correct diagnosis given on the left with each of the clinical scenarios given on the right. Okay, clinical scenario number 1, a 60-year-old woman complains of feeling tired while doing her usual household work over the last 3 months. She has been short of breath climbing 1 flight of stairs at home. Her hemoglobin is 8.5 grams per liter. Abdominal examination reveals a mobile mass in the right ilia fossa. Now, match this clinical scenario with the diagnosis on the left. The answer is D, which is carcinoma of the cecum. Now we come to scenario number 2. A 60-year-old man complains of frequency of micturition, discomfort while passing urine, which is very foul smelling and sometimes contain brown material. On questioning, he admits to passing air bubbles in his urine and recently has been constipated. On examination of his abdomen, there's nothing to find and the urine examination shows heavy growth of E. coli. Now match this clinical scenario with the diagnosis on the left. The answer is A. Diverticular disease of the colon. Scenario number 3. A 70-year-old man complains of constipation for 4 months. He has to take increasing amounts of laxatives to have a bowel action. Following a bowel action, he is left with feeling of insufficient evacuation, and on straining at stools, he passes blood from his anus. On examination, there is nothing to find except some evidence of weight loss as seen by his loose trousers requiring an extra notch in his belt. Now, match this clinical scenario with the diagnosis on the left. And the answer is E. Carcinoma of the descending colon. Okay, these are the answers again for the questions. Now, once again, we come to an end of this session on carcinoma of the cecum. Thank you for your patience, and I hope this session is of benefit to you. Thank you. See you again some other time.